Hello, I'm Mallie Shansfeld, Managing Editor of Endodontic Practice US, a MedMark publication. Before we get started, I would like to invite viewers to use the question box in your control panel to ask any questions, and your questions will be answered at the end of the session. Also, to receive your CE certificate for this presentation, please complete the free CE quiz. The link to this quiz and the presentation recording will be sent to all attendees 1 hour after the webinar completes. Dr. Nasseh and Dr. He, we turn the webinar over to you to learn more about the topic for today.
Hello, I'm Ali Nasseh, and it's really a great privilege to be here with you today. And I'm joined today for the next hour, and so with Dr. Jianing He. Dr. He, thank you so much for joining me.
Thank you, Dr. Nasseh. It's a great pleasure and honor to be here today with you to discuss some more recent development in the field of bioceramics in endodontics.
Absolutely. Thank you so much again for sharing your time here with us. And what we have, Dr. He and I have a great program for you guys today. And we're going to talk about bioceramics and endodontics, promising new frontier or the Wild West. So that is basically talking about some of the understanding of what are some of these what are these bioceramics? What is the difference bioactive and biocompatible materials that are out there? And then obviously we're going to talk a little bit about the research on it, as well as some of the newer bioceramics that are coming out. And what does this mean for us making clinical decisions in this area? We are going to first just thank you guys all for spending your hour with us, as well as doing some disclosures. I'm going to go first here. As you know, I am a clinical endodontist. I've been practicing now for 26 years, and I've done 26,000 clinical cases. I still teach about a day and a half a week at the Harvard Postdoc Endo program, but I'm primarily wet-handed. I also have helped develop many of the techniques and technology and materials that you're seeing today. So I am biased in that way, and that's where Dr. He comes in. Because she's unbiased and she's also a researcher and a wonderful clinician. And to that extent, Dr. He, go ahead and do your disclosures as well.
Thank you, Dr. Nasseh. Just a quick intro of myself. My name is Jianing He. I received my certificate in endodontics and the PhD in oral biology from the University of Connecticut Health Center in 2003. And since then, I've been practicing, teaching, and doing research in endodontics in Dallas, Texas. And I've served on the Research and Scientific Affairs Committee at the AAE, and I'm a member of the Scientific Advisory Board for the Journal of Endodontics. Currently, I'm a clinical associate professor at the Texas A&M University College of Dentistry, formerly known as Baylor College of Dentistry, and also maintain a full-time private practice in Dallas. And like Dr. Nasseh, I've been using these bioceramic materials for over 10 years. And I've also been doing some research of our own on these materials. So I will also be speaking to you based on my clinical experience, as well as some of the research data that we have accumulated over the years. And just to disclose that I don't have any financial interest in any of the products that we'll be discussing today, but I do receive honorarium from the sponsor of today's webinar.
Terrific. Thank you so much, Dr. He. Well, let's first talk about ceramics and bioceramics. As we know, ceramics are these brittle but heat and corrosion resistant type of materials. These are created by usually heating specific kind of minerals, compounds to very high temperatures and then allowing them to cool slowly. The original word ceramic comes from the Greek that is kind of goes back to pottery and clay pots and things like that. But bioceramics are those specific type of ceramics that have some type of a bioactivity. So whether they are bioinert or bioactive and so on, Dr. He is going to mention in a moment here. But ultimately, these materials that are composed of a series of specific compounds, including calcium silicate, phosphate, carbonates, zirconia, and alumina, and some other materials, have some biological properties. Most importantly, they are very biocompatible, allowing the body to not reject them. People like Larry Hench and so on, originally back in many, many years ago in the 1960s, developed and introduced these compounds as biocompatible materials into medicine. And there were later on introduced to dentistry and to endodontics as to the first bioceramic, which was MTA. And a little bit later, due to some of the material property and rather clinical properties of MTA being a little bit difficult in terms of handling and so on, and staining. Other newer generation of nanoparticulate bioceramics that are self-mixed also, such as BC sealer, endosequence BC sealer, RRM, and the putty were developed later on. And then the biodentine, which was a triturable type of a calcium carbonate-based material, was developed compared to the calcium phosphate-based endosequence BC sealer type of materials. Now, these MTA obviously had a body of research that was supporting it for many, many years. And these newer generation of bioceramics, such as the sealer, BC sealer, as well as the putty and the biodentine, also have a lot of research kind of supporting them. In fact, these are the established bioceramics now. MTA originally in 1993 came on the market. The BC sealer came on the market in 2007, 2008, and then biodentine a little bit later thereafter. Essentially, what these materials do is, as a result of the chemical formulation and the reaction of setting, they create a little bit of hydroxyapatite on the surface that makes them very biocompatible. And to that extent, that's what I would like to ask Dr. He about these bioceramic activity compared to what is bioceramics, bioactive, and bioinert, and so on. So, Dr. He, please go ahead.
Absolutely. So we're hearing these terms being used a lot more in recent years, bioceramics, bioactives. So it can get a little confusing sometimes, and people wonder if they mean the same thing. So there is certainly some overlap between the two terms, but they're not the same. Bioceramics, like Dr. Nasseh just mentioned, basically refers to any ceramic material that's used in dentistry or medicine. Bioactives, on the other hand, the term describes more of the biological property of the material. So if a material has the ability to release any biologically active ingredients, then it's considered bioactive. So in the field of dentistry specifically, this definition covers two main groups of materials. So the first group includes those fluoride-releasing materials that we're all very familiar with, like glass ionomer, resin-modified glass ionomers. So these materials are not bioceramics, but they're bioactive. So the new endosequence BC liner also belongs to this group of non-bioceramic bioactives. And of course, the second group of bioactive materials include those bioceramics. So BC is a good example of this type of bioactive bioceramics. And these materials can actually interact with the tissue they're placed in. So I'm going to use BC as an example to explain how bioactivity actually means. So we know that the most important ingredients in BC are the calcium silicates. So as the material sets during the hydration process, these calcium silicates would interact with water in the environment and first form calcium hydroxide. And this calcium hydroxide further interacts with the calcium and phosphate components in the tissue fluid and forms a hydroxyapatite layer on the surface, like Dr. Nasseh already mentioned. We all know that hydroxyapatite is very biocompatible. That's the main mineral component we find in our dentin and in bone. So when this interface forms between the material and the pulp and between the material and periapical tissue, it can promote healing and also induce new mineralized tissue formation. And hydroxyapatite also can form a chemical bond with dentin. So when this interface forms between the obturation material and root canal walls, it can help to improve sealing. So as you can see, there are a lot of benefits in using a bioactive material in endodontics for obturation and to induce tissue repair and regeneration.
Yeah, absolutely. And as Dr. He's chemical formula is showing over there, just taking a look at the formula, you can see that these physical properties are going to emerge, such as biocompatibility, the antimicrobial property because of the calcium hydroxide release, dimensional stability, and in fact, if a little bit, slight expansion over time, hygroscopically, and then the fact that these are non-absorbable, allowing us to use them as repair material where they have to interact against tissue cells and so on, as we know from that biocompatibility and non-absorbability, all of these properties such as bonding and hydrophilic kind of component of these materials help us create these materials, kind of the ideal materials for interfacing cells for best biocompatibility at the present time. Clinical handling, of course, in the case of these nanoparticular premixed materials is also a lot easier by directly injecting it into the site. As a result of these properties, there have been now universal applications of these materials for non-surgical use as sealer, pulp capping, epixogenesis, epixification, and root repair. And then on the surgical side, also for apicoectomy resorption, surgical resorption repair, as well as perforation repair, surgical and non-surgical. These areas have now been kind of established for these materials as being very, very favorable for these applications. Of course, as I mentioned before, we had already done a lot of research on MTA in the specific area. We knew about the use of MTA in these specific applications, of course, not sealer because of the particle size of MTA being so large, but later on, with the addition of the syringeable nanoparticulate type of materials and the biodentine, we found that this kind of applies to them as well. The advantages are the fact that better handling properties with the second generation materials. MTA had also some bismuth oxide causing some staining and other issues related to that. But now, as you have seen, as this over the past 12 years, the use of these bioceramics has become now mainstream. Now there is a delusion, a whole plethora of different brands, international brands, and so on, coming into the market in North America, talking about these bioceramics that appear to look like any of these established ones. And we're trying to figure out if these are in fact going to be the same, they're going to behave the same, because these are at their infancy. There's still no research supporting them. We just want to make sure that we are, as consumers, protected in this particular area. So to that extent, I want to ask Dr. He, who has the background research in the bioceramics and so on, to kind of just let us know in terms of some of the pros and cons of the use of these newer bioceramics, and what are some of the areas that us as consumers and clinicians should be aware of and be concerned about.
Sure. So for clinicians, I think it's always good to have more options, always good to have more products to choose from. But I just feel that we need to be reminded not to generalize all these different new materials as being more or less the same, just because they're all marketed as bioceramics. And like you said, many of them are even made to look like the more established materials. We can't assume they all behave the same. You know, materials like MTA, biodentine, and BC, these are considered proven materials because they've been around for a long time. They've been thoroughly researched and studied. Their success is very well documented. While these new materials, on the other hand, are really largely untested. There's really very little research supporting their use. So we just have to be diligent with these new products. We need to look at their material safety data sheet. We need to look to see what's in these materials and look for scientific evidence to support their use. So this is very important because we probably can all think of a few examples when we consider the latest, greatest materials only ended up failing after a few years in patient's mouth. So one such example would be the Resolon Real Seal system. You know, many endodontists of our generation probably remember the material very well, although it's no longer on the market, but it certainly left a big mark in the history of obturation. So it first came out around 2004, 2005. I remember there was a lot of excitement around the material because the concepts associated with Resolon, forming a monoblock, immediate coronal seal, root strengthening, all these ideas are very attractive. And even earlier research showed these materials to have good properties and even similar clinical success compared to Valpercha. So a lot of the endodontists, including myself, got on board and started using the material. But as time went on, we started to notice problems as cases coming back with big lesions. And when we went back in to retreat these cases, we see this type of discolored, partially degraded material in there. And we finally decided to document these cases and published our findings in 2017. What we found was cases obturated with Resolon had 5.7 times greater chance of failure compared to cases obturated with gutta percha. So this is really pretty astonishing, as it's hard to think of another example in recent endodontic history with this type of failure. So, and here is an example of such failed cases. You can see tooth number 18, no pre-op lesion, was a vital case, and post-op radiograph shows really good quality obturation. Yet 6 years later, you see this big periapical radiolucency with some apical root resorption and some broken pieces of obturation material floating around in the periapical lesion. So the material was removed from the market in 2014, but the damage was already done. Many of us are still retreating these cases. So the point of talking about all this is just to remind us not to be too quick to embrace a new material before seeing all the evidence, before seeing all the testings, and before seeing long-term clinical follow-ups to make sure the material can stand the test of time.
Yeah, absolutely. Because Victoria, as you know, as a scientist, also just like chaos theory, small changes can make a big difference in the long run. Over time, these tiny changes can accumulate. And for example, the composition of some of these cements may contain controversial materials or metals, for example. For example, aluminum is an area of concern, correct?
Yes, absolutely. So it is a little bit concerning when we see ingredients like calcium aluminate, tricalcium aluminate in some of these new products, because, well, although there is still some controversy regarding the connection between aluminum and certain neurodegenerative diseases like Alzheimer's, there is pretty conclusive evidence in the medical literature indicating the neurotoxicity of aluminum and its toxicity in other organ systems like the liver and the bone. And these materials, we use them as obturation materials. So they will have the potential to come into direct contact with periapical tissue, especially when we get a big sealer puff. So the ingredients in these materials have the potential of causing having a systemic impact. Although the amount of aluminum in these materials may be small and the overall risk may be low, but we, as clinicians, at least need to be aware of the fact that these materials contain aluminum. So we need to be careful before using these materials on patients, especially when we have aluminum-free options like BC available. There's really there is really not worth taking the risk of using any aluminum-containing materials.
Yeah, it kind of reminds me, Victoria, of the whole amalgam thing with the mercury and some people having some aversion to it. It is controversial, you're absolutely right, but the presence of aluminum in Alzheimer's plaque has been established. Its role in hepatotoxicity in some cases has been established. So maybe even if it's used as a material that could be in a provisional phase and it could be removed, that would be one thing. But if you get accumulation or too much extrusion in the long run interface, it could be controversial. And you're right, if there is a chance for alternatives, that may be the case. And that's the key thing, is to really read the material safety data sheet in the materials that you buy, and don't necessarily just think that it's an equivalent just because the manufacturer is telling us that this is equivalent to this and this with a history of research. Because one of the main points to keep in mind here is that some of the materials out there, such as the biodentines and the endosequence BC sealer, are still under patent protection. And in order for any material to come out and to be exactly like them, that could mean two possible things. That's like they're either infringing on the patent, in which case they're probably going to go away, or they are substantially different chemically so that they can bypass the patent. And if they're substantially different than the patent, then they are chemically different. And as we know, small changes in chemistry can have different biological results. And therefore, it's really up to that specific, each specific product to validate the research and the support for the long-term use, as Dr. He also mentioned, in terms of other products that have had a good short-term outcome, but a bad long-term outcome. So materials that have been in the market now for many years are probably better supported. And for example, a body of research surrounding the bioceramic nanosequence BC sealer of the recent search in the PubMed, you can see about 132 different articles on the bioceramics, of which over the past 15 years. And you see that 90% of those have been on the nanosequence BC line of products. And that research is important in that case. And most of these research are very, very complementary to these products, and many meta-analysis already of the research that has been done on vitro and some in vivo as well. But more importantly here, Dr. He, why is research even important for clinical materials? Many people say, well, look, just research is, we need just clinical history or clinical experience. Why is research important?
Yeah, absolutely. So, but before we get into the research evidence, if I may just follow up on what you spoke about earlier about material compositions, if I may add one more thing there. So you talk about, these new materials may be substantially different regarding the composition, and that's very true. So in addition to the aluminum issue, when we look at the material safety data sheet for these newer materials, you see other ingredients not found in BC, such as calcium sulfate, iron oxide, and even mineral oil in certain some of these new materials. So what these ingredients will do to the material properties, we really don't know. And that's the main problem. These materials are just largely untested. Their properties are just not well documented. So the safety and the effectiveness of these new materials really still need to be tested. And so now we can move on to look at research supporting these more proven materials. And I consider research very important, not because because I do research myself, because this is part of the evidence-based dentistry. We want to practice evidence-based dentistry whenever possible, which means that when we make a clinical decision, in addition to considering the clinical circumstances, our training background, patient preference, and certain practical considerations like the material cost, convenience and simplicity and handling characteristics, we also want to look at the most up-to-date, clinically relevant scientific evidence. And where does this evidence come from? If we may go to the next slide, please. So the evidence can come from in vitro testings, animal studies, as well as clinical outcome studies. We can look at some of these in vitro studies first. So for a material intended to be used in endodontics for obturation and to induce tissue repair and regeneration, the most relevant properties that we're interested in include biocompatibility, antibacterial properties, and sealing abilities. So we can take a look, if we can go to the next slide. Here are a few examples of studies on the biocompatibilities of BC and wood repair material putty. These materials may have some initial cytotoxicity because of their high pH, but overall, both materials have been shown to support and encourage cell attachment and growth. They can also promote osteogenic and odontogenic differentiation, which means they can lead to more new bone formation and more reparative dentin formation. Next, please. The antibacterial properties of obturation material are also highly desirable because we all know that there isn't any instrumentation system or irrigation system out there that can achieve 100% disinfection of the root canal system. So a lot of times when we obturate, there can still be bacteria left behind. So we have to rely on our obturation material to kill or at least inhibit the growth of these remaining bacteria. So both BC and root repair material have been shown to be effective against E. faecalis. Ephecalis is a bacterial species commonly found in an infected root canal space, especially in retreatment cases. And the root repair material has also been shown to have some antifungal properties. If we can go to the next one, but the in vitro studies on sealing ability are a little less consistent, largely due to the variations in the methodology used in different studies. And there is also a lack of a reliable, reproducible in vitro model to study sealing ability. So although there are a lot of studies that show BC to have less leakage, higher push-out bond strength, and better dentin tubule penetration, we do need to be aware of the limitations of these in vitro models. So I don't want to overemphasize the importance of the in vitro data. Ultimately, what matters at the end is clinical success. So I think we should definitely place a bigger emphasis on clinical studies. So as Dr. Nasseh will start to go over some of the clinical applications of the bioceramics, I will jump in from time to time to share some examples of the studies I consider important as they relate to each area of these applications.
Perfect. Thank you so much. So what we're going to decided to do for you today is to share 3 of the main applications of these bioceramic line of products and some of the clinical techniques for their use. Obviously, as I mentioned before, there's many applications, in fact, universal application in every aspect of endodontics, but these 3 are the main ones. So we're going to talk about vital pulp therapy, endodontic obturation, and surgical root end filling. And vital pulp therapy, especially apropos in the recent release of the vital pulp therapy position paper by the American Board of Endodontics that Dr. He and I have been actually kind of fond of and had a discussion on very recently. So we think it's a very important position paper as it essentially talks about the change in the past to the present in terms of the diagnosis, moving away from the idea of irreversible pulpitis, right, Dr. He? Now a new definition of irreversible pulpitis from an all or none, you do a root canal, you don't do a root canal, to maybe a gradation from initial mild, moderate, and severe pulpitis, and potentially having to decide at what point can you do vital pulp therapy or not. Do you want to comment on that?
Yes, absolutely. So I think this position statement is really exciting, where it actually officially legitimize the use of vital pulp therapy, because more recent research is definitely indicating vital pulp therapy to have really high success rate. Is very different from the traditional vital pulp therapy when we use calcium hydroxide as the pulp capping agent. Back then, it was considered as an unpredictable treatment option, only indicated for certain cases like trauma, pulpal exposure caused by trauma, or healthy pulps. So this statement really broadened the indications for vital pulp therapy. However, regarding the pulpal diagnosis, I think there is still some questions remaining. Like Dr. Nasseh just mentioned, the distinction between reversible versus irreversible pulpitis is still not very clear. It's definitely a gradient. There isn't a clear cut off where we say if cold lingering pain to cold more than 5 seconds, that's irreversible, that you need to do root canal treatment. If it's less than 5 seconds, you can do vital pulp therapy. It's not like black and white. So I think we still need to figure out the exact indications for vital pulp therapy, and there still needs to be better, more precise diagnostic tools to help us to understand the status of pulpal inflammation to guide our clinical decision making.
Yeah, clearly. I mean, it seems that some of the verbiage in the paper has been left purposely kind of vague, allowing a little bit of subjectivity to kind of infuse into the decision making, which is a double-edged sword, obviously, as many things in the past. But I kind of look at this as an historical type of a paper in a sense, because it finally opens up a potential for what oncologists and plastic surgeons, for example, went through in the past few decades. For example, in the case of breast cancer, the treatment of choice was a full radical mastectomy until the data became available where a potential partial lumpectomy was essentially a successful. The key becomes a question of finding the problem early enough where you can actually interfere and almost in the same way as cancer spreads out but leaves areas that are unaffected. You can think of pulpitis kind of having that gradual kind of dispersion throughout the pulp, and the goal becomes to only remove that part that's pathologic. And of course, for that, we're going to need in the future markers that are going to hopefully tell us better where that starts or stops. But at the present time, Dr. He, I think we're just going to have to suffice with using a proxy such as bleeding, right?
Absolutely.
Terrific. So, well, but given this, that we now know we can do more vital pulp therapy, the idea of vital pulp therapy has been that to, let's say in a case where we're having pulpitis that's in initial phases, what we used to call maybe reversible pulpitis or just early irreversible pulpitis, you're going to go in there, remove all the infected decay, remove also the affected decay. You may end up getting a pulpal exposure. At this point, you're left with a situation in which you need a material that is going to interface cells for which you're going to need the most biocompatibility, and that we just established that bioceramics as a whole are the best type of material, pure bioceramics. And that's another reason why, Dr. He, they need to read the MSDS, because a lot of them, as you said, contain oils, they may contain resin, a lot of these things. And so it's important to kind of keep track of what is the pure bioceramic, and then we put that against the cells. But then we now are dealing with a question. We have the best biocompatibility on one side, but the other side, we need to have an interface with restorability. And bioceramics, although pure, they always have a very long setting time. And even some of the ones that have tried to remove the calcium phosphate component, use calcium carbonate, such as biodentine, they still have a long enough setting time that clinically you're still going to require some type of a interface here. And that's where this, we would use the bioceramic, but we need to have something that's going to interface the bioceramic that is still on set. And that's why this new material is what we developed, which is a bioactive type of a resin ionomer that has been optimized to work with the bioceramic line of products. It works with the endosequence species sealer, biodentine, or with MTA, and it comes in a blue and a tooth-colored version. And the idea here is that you are going to place the putty bioceramic or even the syringeable material as well. You have to have a clean ring of at least 2 millimeters of dentin around the material, so that allows the self-etching and the self-bonding to occur. You don't want to do what I just showed here in this video. You don't want to place it and immediately light cure it. You need to place it and you have to wait 30 to 45 seconds for it to self-etch and self-bond the surrounding dentin. And you got to also make sure, if you're using a scope, to have an orange filter so that the initiation process does not start as soon as you start mixing it from the light from your microscope. So orange filter is very important. Otherwise, you're not going to get proper etching and bonding, and it's going to pull back. You're not going to get proper adhesion. So afterwards, though, then this is a technique that I described called the non-surgical lid technique, in which you are using the putty for the most biocompatibility, but then quickly going on and placing the liner on top of it for restorability. So you can fill all the way up to the top in case you're doing quadrant caries control. Instead of using IRM and things like that, you place the bioceramic against the pulp after controlling the bleeding. Then you fill up all the way to the top, and this material will self-etch and self-bond, and you will be able to wait 8 weeks to figure out what's going to happen. If the tooth does well, the pulp remains vital, and you don't need to do root canal therapy. All you need to do is just drill about 2 millimeters into this material and then fill it back up with a bonded composite that's with a surface that can be polishable and so on, because you don't want to have a resin ionomer facing the surface in the long run. And that would be it. Alternatively, if you feel like you've had an indirect pulp cap, or that you're fairly confident it's going to work out fine, or you want to place your final restoration, you can just put a thinner layer of the liner on top of the bioceramic to just cover it. Then you etch and bond it, and you place your bonding agent, and you quickly fill. You're using the liner as a liner here, but you're interfacing the bioceramic. The goal here, the reason why you're having a bioceramic and a liner, is because the bioceramic is the best material for against the pulp. And then you want to have a resonant ionomer on top of that. Just quickly to show you the technique here, this case was testing with reversible pulpitis, which means there was no lingering pain to cold and there was no spontaneous pain. And while we clarify these diagnoses, Dr. He, right, we can still refer to these as reversible pulpitis for the time being. And you can see that we always want to take a bite wing as well here to kind of make sure the biological width and everything is in good shape. And you go in and you start to do your caries removal after proper isolation. We remove the caries, and you have to remove all of the infected and the affected dentin in these kinds of cases. We do get a little exposure, and actually that was just kind of doing a little bit of hemesthesia with the coal area of the gingiva. But here I'm putting hypochlorite, placing it for 2 minutes or so until I control the bleeding right over the exposed pulp, and then go back. In this case, I'm just placing some BC sealer and then come back immediately and place the liner on top of it. You could also use a little ball of the putty as well here. But you can inject directly, or you could use a ball burnisher to place your BC sealer more accurately right on the floor over the pulp. But the key here is to make sure that you have stopped bleeding, right, Dr. Reed? That's the main point here, making sure we've stopped the bleeding. And then after that, this is the immediate look, and then 8 weeks follow-up of that. The tooth is doing well. We have, as you can see, the BC sealer, and I'm using BC sealer high flow so you can see the higher radio opacity of it against the pulpal area and that direct exposure, and the liner on top of it. At this point, the dentist is going in and drill into this and place a layer of the liner. And now Dr. is going to talk about vital pulp therapy and the support for it in animal studies.
That's very nice case, beautifully done. And the success of these bioceramics in vital pulp therapy is not just seen in isolated cases, it's very well documented in both animal studies and clinical outcome studies. So in animal models, if Dr. Nasseh, we can go to the next one and the next one. And in both dogs and rats, researchers were able to show both biodentin and root repair material can induce this type of high quality, really thick and dense dentin bridge formation. And also you notice there's very minimal pulpal inflammation in response to these materials. And the clinical data is also very encouraging. In pulp capping cases, biodentin has been shown to have a success rate around 92%. And this success rate goes up to 98% in pulpotomy cases. In a study with over 200 cases, the root repair material has been shown to have a 99% success rate when it's used in pulpotomies. So as these bioceramic materials are being used more and more in vital pulp therapy, the success rate for the procedure has been greatly improved. And I just want to share this case report from one of Dr. Rukuchi's publications from last year. This just beautifully documents how the pulp tissue respond to BC sealer used in the vital pulp therapy procedure. So you can see this patient doesn't have very good periodontal conditions. He doesn't have a lot of teeth left. So you are looking at tooth number 6. The treatment plan for him is to remove all the remaining teeth and make him a full denture. But as you can see in the clinical photo that there is some cervical decay, so the patient has some pulpal symptoms. So he wants to have some relief in his symptoms before treatment plan can be finalized, before all the teeth can be extracted. So pulpotomy was done. And BC was used to be placed over the remaining healthy pulp tissue. So the tooth was extracted a month later. And on these histological sections, you can see in the remaining pulp tissue underneath the material, there are some irregular areas of calcification. But overall, the pulp tissue looks very healthy with barely any inflammatory cell infiltration. And you can also start to see some areas of newly formed dentin bridge. So although this is just a case report, but it is very valuable in vivo evidence comes from a patient that shows this material, BC sealer, is very well tolerated by the pulp tissue and is also able to induce very nice dentin bridge formation.
Terrific. Thank you. So let's talk about the second clinical application for root canal obturation, which is the bread and butter of what we do clinically as endodontists. And the idea that we've had historically different types of obturation to address the problems of sealers by trying to really condense the gutta percha to thin out and minimize the interface, minimizing the sealer interface, if you will, has been the axiom that we've used clinically. It wasn't really until the problems of the sealers were addressed with this new generation of bioceramics that we managed to develop simpler obturation techniques that would be as effective here, using, for example, hydraulic condensation, which is a technique that we developed with the original bioceramic and the BC sealer. And the reason for it, this technique works so well, is that it uses the sealing ability of the bioceramics, but instead of using the full bioceramic to seal the canal, which would make it very difficult to retreat, we wanted to develop a responsible technique that could be retreatable. And so the idea of having a main cone that fit and filled the main port of the canal allowed not only control of the sealer all the way to the apex, not only add a little bit of hydraulic pressure sideways so we can get a little bit pushing of the sealer into the nooks and crannies of the canal, but more importantly, also provide a path for revision so that if a case is still not clean and shaped adequately, or if somehow we need to go back and down the line and revise this tooth, we can easily do the revision by melting the gutta percha in the center and then removing a layer or two of the dentin on the side and get good cleaning. This is kind of similar to the idea of post cementation, in which when we are cementing a post, and posts are obturation materials in the canal, if you think about it, 3/4 of the canal's post filled with that, but we're relying on the cement to allow the seal, and that's what they do. But here we're relying on the sealer to do this, to provide us the seal. So these are cement-based obturation. It's called hydraulic condensation. It's not called single cone because you're not limited to use a single cone. You can use as many cones as needed if there is it's a big oval canal, and that's really the main thing to keep in mind. So if you have a round canal, you'll end up with gutta percha and just a little bit of sealer interface on the side. If you have an oval canal, you end up having a little bit of more bioceramic on the sides. But the goal here is you don't want to fill the whole canal with the bioceramic, which even though you can, and maybe in a central incisor with trauma, you want to fill the whole canal with the bioceramic, you certainly can, as we used to do those with MTA many times, with cases of, barrier technique and one-step apexification. But for the most part, you always want to have a gutta percha in the center so that the tooth can be retreatable. So we don't want to do this if we can avoid it. And retreatment has been now shown through a number of studies to be no different than any of the other techniques, with excellent and efficient revision available and possible. And in this one study, you can see that actually with the use of an XP retreatment XPR instrument, you can actually remove, for all of the techniques used, you get much better results in terms of cleaning of the canal in this area. So with that, I'm just going to quickly show you a clinical case of this gentleman here who needed a root canal on this maxillary first molar, which on the regular x-ray, it just showed with the regular case of irreversible pulpitis following a crown that had been placed many years ago. But now we can see that the crown had decay under it, and it had caused some internal resorption. As you can see here in the palatal root, you can see that defect on the palatal root being usually, as we know, internal resorption is somehow, in some cases, related to some persistent coronal inflammation that is present in these canals. And you can see that in the regular x-ray, PA was not showing it, but it was really the CT that allowed us to see it. So in this particular case, we go in and make an access preparation through this zirconia crown that he had, or lithium disilicate, actually I don't remember right now. But either way, we make an opening in there on top, and just use this blend protocol that I use. We've helped develop with the idea of austenitic and martensitic files, and this 3D file to go in and clean that area of internal resorption in that area, and get all of the canals, the MB1 and MB2 were joining together to get them to a size 40-04 endosequence, and do our irrigation and disinfection. I'm using negative pressure at the very end. And then go ahead and place the sealer. The idea and the technique is we place the sealer up coronally in the coronal half of the root, and then push it down. In this particular case, I just used the 3D instrument also to push the canal and coat the canal walls. You could use a regular file with that, a hand file or a rotary file, put in reverse. and then coat the canal again a little bit, and then seat the cone. In this case, we ended up with a 4004. There was only room for one cone in each canal. So we put the 4004 in the paddle, and you can see I only melt the gutta percha about 1 millimeter or so above the orifice and come back immediately while it's still molten with a largest plugger, Schiller plugger, like a size 10 plugger, and melt and then plug it down, almost creating a nail head that allows me to then cover the entire orifice with gutta percha. So after I remove the sealer with the ultrasonic and water, where it comes out very quickly and cleanly, then I'm only showing gutta percha at the orifice level, as you can see. Then I follow that up with placing the BC liner. Usually, I would prefer that we all use blue BC liner at this point to fill the canal. It's a little bit of an older case. I would be using blue BC liner right now so that it could have enough contrast later on to be able to see it. And this is the post-op. And you can see that this is just hydraulic condensation with 14004 cone in each canal. And the BC high flow, which is what I use now. I use the high flow version primarily, I'll be honest with you, because it's more radio opaque. It's not going to give you a better success rate than a conventional BC sealer, but the high flow is what I prefer because you get a little bit better flow. You can do a little bit of damp pack if needed. And it's more importantly, more radio opaque, so cases look a little bit better as well. And you can see that on the post-op x-ray, we took another 3D here to show that we have filled the area very well, and it's just kind of stripping the root. We can see how this case looks following endodontic therapy in all of the canals, and that area, this internal resorption, is filled without any type of kind of a perforation. So Dr. He, please go ahead.
Yes, that's really a beautiful case. And what's even more impressive is you did all that work through a very conservative access. So now let's look at some research. So as we discussed earlier, we should definitely place a bigger emphasis on clinical research because they provide the most relevant information to clinicians. But clinical studies are usually more difficult to do compared to benchtop studies, takes a lot more time and effort, and that's what the newer materials are lacking. Although there are a few in vitro studies on a couple of these new materials, but there isn't any clinical publication on these materials. So this paper we published back in 2018 is an outcome study on the BC-based hydraulic condensation technique. This was a retrospective case series that included over 300 cases treated in our private practice. It included both initial treatment and retreatment cases, both cases with pre-op lesions and cases without pre-op lesions. So all these cases were obturated using BC with the hydraulic condensation technique. All of those were treated in a single visit. So we found the overall success rate was close to 91%, which is well within the success rate reported in the literature for these types of cases. And this study also included many cases with long-term follow-ups. The longest follow-up time in these teeth was 85 months, which is more than 7 years. So it's very long-term follow-up. So although we are well aware that this study by no means is considered high-level evidence, but it does offer some very clinically relevant information, because we know based on this study, if you use this material in this technique on these types of cases, this is the type of success you can expect in the real world. And this is another outcome study on another calcium silicate-based sealer. It's BioRoot RCS. It's a product from Septodon. It's not a pre-mixed sealer. You do need to mix it before use. So this study compared cases obturated with BioRoot RCS in a single cone technique and cases obturated with AH+ in a warm vertical technique. And they found no difference regarding success rate between the two groups. And their success rate reported 90% is very similar to what we reported for BC. So based on these studies, we can see these calcium silicate-based sealers offer a comparable clinical success as the more conventional materials and more conventional techniques, but they offer the additional benefit of allowing us to greatly simplify our obturation technique without compromising the quality and the outcome of obturation.
Yeah, terrific. And we did, Dr. He, a similar type of a pilot type of a study, really not a proper success failure study, but one of survival. One of my residents came to the office, and as you know, over the past few years, I had done many of these cases. So a 5-year follow-up of these patients, what we did by just phone call and talking to these people, because we couldn't get everybody back to do a full CT scan and X-ray, but we called them 5 years following the treatment using hydraulic condensation. We found that 97% of them still had the tooth and they were asymptomatic. And I think that was really helpful just to kind of know that was done back in cases that were done in 2010 and then followed up in 2015 to just see what percentage of them still had the teeth. And like I mentioned, that we had a very good retention rate, and that's really helpful to know just from that perspective. All right, so last but not least, let's talk about surgery, something close to my heart, as I'm now the director of the surgical program here at our school. I teach the surgery course and so on. And so I think that the one of the most underrated applications of these materials would be for surgery, and that is some of the most important application. We obviously knew with MTA, but the problems with MTA was that it would wash out over time, and it was difficult to apply. It would take a long time to kind of apply that mud material to the end of the road. Biodentine was slightly better. What's nice about a technique that I've helped develop here for the specific application, and that's basically the genesis of the putty. Since the putty didn't exist, the putty really came in order to fulfill this particular technique, which I wanted to use for more efficient retrofilling, because efficiency of retrofilling is super important, because all of us know we only have a small window of time for hemostasis as well as anesthesia, and also the fact that the quicker your surgeries, the better the outcome, as you create less inflammation and less post-op pain. So less hemostatic agents and chemicals that you use during your surgery, the less post-op pain patients are going to have. So if you can, just using natural methods of pressure and just adrenaline, be able to get adequate hemostasis for a mere 20 seconds, you would be able to apply a retrofilling. Not only you get a much more efficient technique, a much more efficient flow of the process and quicker type of a procedure, but most importantly, your patients are going to have less post-op pain because you did this so quickly and you didn't apply a lot of caustic and pro-inflammatory type of chemicals such as ferric sulfate and so on during your surgery. So the technique is very simple. It's inspired from my experience in the pros lab as a dental student by the idea of using light body and heavy body impression materials. The idea is that you inject the BC sealer, the flowable syringeable material, into the canal, and then because the material takes 4 hours to set, and if you just leave it at that after you close up the lesion, it could probably wash out of the canal. What you would then do is you would take the more tenacious putty material and put it right on top of the material like a lid. And that technique could be done very efficiently by simply injecting the sealer using a newly developed type of a tip all the way to the end, just like you would fill with the obtura gun, and then come back and place a layer of a lid of the BC putty fast set, which is very tenacious, been specifically kind of designed so it doesn't wash out when you kind of do a little hydrocarving in there with water. And that's the key. And this new tip, which is the minimal waste tip surgical tip, has a 90-degree bend. It's about 10 millimeters length of this tip that you could trim to length based on the depth of your retrofilling. You could go all the way up to a post and fill it all the way back up and so on. And you just trim, but the key is to make sure that the tip of this thing goes all the way to the base of the retro preparation so you don't trap a void before you inject the sealer and you bring it out. That's just like the same way you would backfill with your thermoplastic gun. You got to take this all the way to the base of the retro prep. The idea is that you have, for example, in case you're going to do a apicoectomy retrofill on, you go in there, you remove all the gutta percha, and now you have these longer ultrasonic tips. You clean that up, and then you place this retro tip in there, and you inject as you back out, so you can fill the whole thing up, and then you come back and put a little plug of the putty on top of it to protect it while it sets, and you can see you get very nice results very quickly with this technique. So cases like this, you can see even on molars where you have this type of a shape with two mesial roots of a mandibular molar that have had, there's an isthmus. As we know, a lot of times these problems are caused by an isthmus in the mesial root. infections that are limited to the mesial root of a lower molar are due to this isthmus. So you create your retropreps in each canal, and then you connect it through the isthmus. And then here it's an older one, so I'm using just a different type of a tip. But now with this newer minimal waste tip, you can easily go all the way down. You can make the putty that comes afterwards into a little cone if you want, but I've now found that you really can just simplify it, just turn it into a little ball, because you really need to have just a thin little amount of the material up at the surface of it. And you can see here I'm putting it all over the isthmus and each of the lingual and the distal canal. As you just saw, this entire retrofilling here for you did not take long at all. And then what happens is that I come back, add a little water, and then I use a micro brush to remove the flash, and then use water to wash out the dislodged flash here. And you can see this is not something we could have done with MTA before. It would wash the whole thing out, but the putty fast set does not wash out that easily. And here it is. And even if you have a little tiny flash, you can see here, it's not a big deal. And here's a little angled X-ray showing each one. You have, especially with the high flow, you have also a much more radio opaque retrofilling. So that's the best material to combine. I use the BC high flow and the BC putty fast set for this technique. And you can see your recall here. The lesion is filled up here with the bone. And I didn't even use a grafting material. So Dr. He, what about surgery?
Time to look at a few studies. So we have a few more studies on the root repair material compared to the studies we have on BC. So 2 of these studies came out of our group. The first one was based on cases treated in our practice. So this was also a retrospective case series with over 100 teeth, mostly posterior teeth. And we found that when we use root repair material as the root and filling material, we're able to get a success rate of 92%. And the second paper, if we can go to the next one, was based on cases treated by our residents at the dental school. So this study also included a control group where we used MTA as the root and filling materials. And as you can see, there's virtually no difference in success rate between MTA and root repair material. So as you can see, even in the hands of less experienced residents, they were able to achieve a very predictable success using this material and this technique, because the materials and handling properties of the material allow us to greatly simplify the technique. And this paper is from Penn. It's a randomized controlled trial, so it offers the highest level of evidence. So they compared the success rate between root repair material and MTA, and again, no significant difference between the two materials. And so you can see all these studies are highly consistent. All of them show root repair material to be able to achieve very predictable success used in this technique as a retrofill material.
That's terrific. So, and also one additional research that I'm currently undertaking with one of our dental students here at Harvard, as well as similar thing that I did with the non-surgical cases. We're having we had her pull about a 10-year period from 2000 to 2010 to 2020. All the single-rooted apical cases that I had done was about 300 some cases, and apicoectomy, and then she managed to call and get a hold of about 100 and some of them, and we asked them if they had still the tooth and if they had any discomfort, and we found that 92 and some percent, 92.5% of them, they still had the tooth and they had no symptoms, showing that again this techniques using these materials with the lid technique now combined with the idea of bioceramics works as well. So we talked about these three things. In conclusion, I just want to say that obviously the bioceramics and bioactive materials have certainly changed the way we do endodontics, and they will continue to positively impact our clinical endodontic therapy. And also that while these materials have excellent clinical properties, it's all of us as clinicians, we really have to be diligent, and we have to research in order to select the clinically proven materials that are backed by research to help us improve the efficacy and safety of their care. Because Dr. He, I'm sure you agree, we mentioned with the idea of the Wild West, kind of this area is still pretty unregulated. People are calling whatever they want on this side. And kind of reminds me of the old days of the wine industry, where you could just put on a little, single Cabernet grape in a bottle of very cheap, Sangiovese grape and call it a Cabernet, and then obviously sell it. And it wasn't until it kind of regulated that market and realized that you can't call things whatever you want, that it became kind of a little bit of a more regulated market that is working. But we're currently not there with bioceramics. So it's really up to the clinicians, correct, to kind of follow up on this.
That's a great analogy. And I definitely agree with what you just said. So there are a lot of more products in the market of bioceramics, because these bioceramics are such wonderful materials, because they really changed, like Dr. Nasseh said, changed the way we practice. They really allowed us to simplify our operation techniques, our surgery techniques, without compromising the quality of our treatment. So these materials have really been thoroughly tested. As you can see, there is a lot of data supporting the use of these materials. And these new products just barely have any track record and very little research. And like I mentioned earlier, there are a few in vitro studies on a couple of these materials, but for most of these new products, there's virtually no independent research, very little published data. So these materials just need to be put through the same testing, and we're yet to see what the data will show. So before we can see the evidence, I think it's a good idea to stick with the scientifically and clinically proven materials like MTA, root repair material, and BC sealer.
Yeah, thank you so much. And we want to thank you for your attention. And I think what we're going to do is we don't want to go too far over the time. Dr. He, maybe you can start reading some of the questions, and I'm going to search as well. Do you want to read the first one, or should I read?
I actually do not see any questions here. So if you can.
All right, let me see. Okay, so what about TheraCal as a bioceramic?
Okay, that's a great question. So TheraCal is an interesting material. So on the surface, it seems like the perfect material is marketed as a light curable bioceramic. And so it has the good properties, supposed to have the good properties of bioceramic, but it's light curable, so gets around the problem, the main limitation of the bioceramic, which is the long setting time. So it really sounds wonderful. However, as you take a look at the material safety data sheet, you will see it has about 30 to 50% of Portland cement, and the rest of it is resin. So when you add resin to calcium silicates, actually it greatly interferes with the hydration process. If you remember from the beginning of the presentation, you remember that formula. So this hydration process is critical for the bioactivity of the material. So when you add resin into the mixture, it greatly inhibits the formation of calcium hydroxide and greatly inhibits the release of calcium and hydroxy ions. So actually defeats the whole purpose of having calcium silicates in the mixture. So I think, in my opinion, when you add resin and the other materials into the mixture, the material can no longer be considered true bioceramics. And actually,
go ahead. You go ahead, please.
I'll continue. The research on TheraCal and similar products like MTA Filopax has been very consistent. All of them show this type of material, this so-called hybrid material, to have higher cytotoxicity compared to the true bioceramics and the lower success. So I don't consider TheraCal a true bioceramic material.
Yeah, not only that, what I think, let me actually stop sharing the screen here so we can go full screen. One of the things here is that when we talk about some of the advertising, if they call that, for example, the best of both worlds. And the reality is that there's no such thing as the best of both worlds, right? I mean, we can either get the average of both worlds, because each properties of these materials end up somehow canceling each other. If your bioceramic would be kind of captured by the resin, so you don't get the full properties of the bioceramic, nor do you get the proper bonding from the resin and so on. So you get the average of both worlds. The only way, that's part of the reason why what we wanted to do here was to make sure that with the technique, with the lid technique, is instead of getting the best of both worlds, we want to get the best of each world by having which is, best of both worlds means the average of both worlds. So instead of getting the average of both worlds, I want to get the best of each world by having the pure bioceramic and then having a resin on top of that so that you could place your material. This way you don't contaminate your site with the presence of any cytotoxicity from the resin. So here's a question, is BC sealer retreatable? I think we mentioned that, but anything you want to add to that?
Yeah, so as you mentioned, really, as long as during your treatment, you have gut puncture in the center, if your gut puncture cone is placed to length during initial treatment, retreatment is really not a problem because you can remove that gut puncture core using conventional retreatment techniques with heat, solvent, and mechanical instrumentation. Then the sealer left on the walls can be removed with a combination of mechanical instrumentation and active irrigation. And like you mentioned, the 3D finisher is a great supplement to help to remove any residual BC sealer on the canal walls. So, and we've done a lot of cases using BC and this technique. We all retreated our fair share of cases, and this has really never been a problem. I know in the literature it's a little bit confusing because there are a few studies that do show it may be more difficult, may take a little longer to retreat cases with obturated with BC, but there are some issues with study design. For example, actually we published a study back in 2011 where we purposely obturated one group of teeth, placed the gut puncture purposely 2 millimeters short from working length. So the apical 2 millimeter was filled with BC only. So in that group, we did have some difficulty regaining length, regaining patency. But looking back at that study, we realized the study design really is not very clinically relevant because although sometimes your cone may not be fully seated, maybe the little 0.5 millimeter or so space filled with sealer, but you rarely have to go through 2 millimeter of completely set material. So when you have a little bit space, even if it's completely filled with BC, it's not gonna be like hitting cement, hitting a wall. A lot of times you can pick through that set sealer using a small hand file, or you can use ultrasonic files, ultrasonic instrument that can also help you to regain patency. So in my experience, retreatment really hasn't been an issue at all.
Yeah, it kind of sets like IRM, so you can't pick through it. It takes some time, obviously. Another thing that often comes up is that, that's part of the reason why we wanted to have hydraulic condensation, and we emphasize as a technique that you have to make sure your cone is fully seated to the full working length that you work through, so you're not leaving this area of additional sealer at the end. And then people say, well, yeah, but people are not using this right, and they're kind of ending up short, and they have a lot of sealer past the thing. And I always say, well, look, you can't blame a technique for people not following it correctly. It's the same argument you could make for saying that people should not be using nitrile rotary files because some people break them at the apex and then you can't get around the canal. Therefore, you should not be using nitrile rotary files. That's not the solution. The solution is to use the technique properly so you don't, misuse it and end up with potential problems with it. And I think that's pretty much, there's a few other questions, but I don't want to run so much over time here since we are kind of limited in time. So I think what we should probably do is we're already been past the hour. We should probably cut it off and encourage people to kind of follow us. And you can email, I had my email on the over there with nasseh@hstm.harvard.edu. You can email me directly there. You can obviously also find us on social media, Facebook, YouTube. Obviously, YouTube is a big place. We put up a lot of videos and so on. But I think with that, Dr. He, I'm going to sign off. Thank you so much for joining me.
Thank you so much. It has absolutely been a pleasure to be part of this discussion. Thank you very much.
Thank you all and have a great day.
Thank you, everyone, for your questions and for attending this endodontic webinar. A special thank you to Drs. He and Nasseh and to our sponsor for this webinar, Brasseler USA. To receive your CE certificate, please be sure to check your email in the next hour for instructions on how to complete the free CE quiz associated with this webinar. The email will also contain a recording in case you missed any portion of the presentation. Thank you again.